Good morning, and well, thank you for coming back. So a couple things real quick. We're gonna make it quick because I know we're running a little behind. We're still doing some level setting, some getting to know, some background. We will get more in-depth in conversation, direction, and planning in future, what it looks like. Kind of what I had thought was, one, we would look at the plan we have in different intercept models. But I had a conversation this morning, and by the way, if anybody who is not familiar with competency in this process and you have questions and you don't feel like this is like the group setting is the way to do it, I do come about half hour before every meeting. I come early. I get it. Like this is not my background. It took me like a year to really start grasping all of this, and it was a year being inundated every day with this topic. So totally open to meeting beforehand for a half hour. The meeting will start at 9:30. They should be regularly set on their calendar, but I'll show up at 9 o'clock. And if you want to come, you can. If you don't want to come, that's fine too. But I am reserving that time for folks that this is not your wheelhouse. You just sort of have some basic questions. We're not going to get into sort of the like visioning and planning in those meetings. We'll get more into just answering questions. And that's what I have. We will get into, I know in the beginning it's a lot of level setting, but we will get into time as we go on into sort of what planning looks like and what the opportunities look like for this committee to propose. Again, proposing statutes on the table, so is proposing to the potential resources needed to solve this issue. So, Allison?
Hi all, thanks again. I'm Allison Butler from Disability Law Colorado. I'm co-chair with Robert. I cannot be here early. I've got little ones to drop off, but if you do have a question that you want to email me, please feel free to do so. I just want to say thank you, and yes, we definitely are looking at it, just sort of making sure everybody's on the same page, but that's not what this subcommittee is for. It is genuinely to help us come up with a new plan. So please do be thinking about how we can make things work, and in the thinking stages, just regardless sort of money or resources, let's try to talk through things.
Very good. Thank you both for that introduction. We'll go ahead and also intro everyone else, including members of the subcommittee and members of the public briefly. I'm going to start with Zoom members, if we're okay with that. If you could remember to unmute yourself. And today we're going to just announce your name and the organization that you primarily represent. We'll start with members of the subcommittee on Zoom.
Raina Shaner, lived experience, Western Slope.
Hi,
Great.
Laura Warner, San Juan Basin Public Health.
Thank you, Raina and Laura. We could hear you, but not well. So we'll work on that for the audio in the room. Lacey, are you there? Okay, Lacey, you might be on mute. We can't hear you in the room, but we'll go ahead and keep things moving around. If you would, Judge, I'll pass to you, please.
Joy Hart, Chief of Behavioral Health for Colorado Department of Corrections.
Mary Thomas, and I have lived experience with mental illness, and I'm from Longmont.
Brenda Pace, Pueblo County Attorney's Office in the Mental Health Division.
Sue Coffey, I'm a parent. I work in film and television, and this is all new to me.
Callie Toll, Director of Forensic Services at Summit Stone Health Partners.
Corey Robinson Rosenberg, Professor of Pediatrics and Psychiatry here at Anschutz, and I have a particular interest in people with intellectual disability and autism.
I'm Linda Niebauer from the Farley Health Policy Center and work with Jonathan and Emma.
Hi, Peggy Heil with Department of Public Safety in the Division of Criminal Justice.
Good morning, everyone. My name is Derek Harvey, and I'm the Chief of Police in Canyon City.
Good morning, everyone. Summer Gathercole with CDHS.
Good morning, everyone. I'm Brian Gonzalez. I'm the Assistant Dean for Academics at the Graduate School of Social Work at DU.
Good morning, everyone. This is Moses Gurr with the Colorado Behavioral Healthcare Council.
Ben Harris with the Department of Healthcare Policy and Financing. We run Colorado's Medicaid program.
Again, Allison Butler from Disability Law Colorado.
Robert Werthheim, Young's Behavioral Health.
Kyle Brown, UC Health.
Sasha Rai, Denver Sheriff's Department Health Services and Denver Health.
Excellent. Thank you all. Any members of the subcommittee in the room that we missed? Looks like everyone's at the table. And now we will switch over to members of the public.
My name is Margaret Elmer, and I'm the President and Executive Director of NAMI Colorado, and also I'm a parent of a person with a severe mental illness.
Good morning. My name is Tim Lane. I'm with the Colorado District Attorney's Council.
Hi, I'm Stephanie Soley. I'm a project coordinator with the Office of Behavioral Health.
Hi, I'm Madeline Rubel with CDHS.
And Mark Techmeyer, CDHS.
Hello, I'm Catherine Davis. I'm with the Office of Behavioral Health and the Outpatient Restoration Program.
I'm Dorinda Robinson, also with CDHS Outpatient Restoration Program.
And any members of the public from Zoom that we need to introduce?
I'm Carol Collier. I'm a psychiatrist at Colorado Mental Health Institute at Pueblo. I also work at La Vista Women's Correctional Facility, and I'm also a parent of a young adult with mental health issues.
We also have Sherry Rapinski from Rocky Mountain Human Services.
Great, thank you all. So again, just to kick things off this morning before we dive in, we want to revisit some of the, one second.
Adam Zerner from the Governor's Office.
Great, thanks, Emma. So we wanted to revisit some of the group operating agreements, again, just to ensure that everyone's on the same page, that we have some alignment in our goals and strategies for working together. A few of these we reviewed all of these we reviewed last time, and we have a few additional comments as well. You'll note in red some of the additions that we've made to some of the team operating agreements. So I'm just going to run through these really quickly, and then if anyone has a question, comment, or addition that they'd like to make, please feel free to do so. Again, we want to remember that we're all trying to do good work here and trying to do our best to meet the needs of the population. I think the extent to which we are focused on the individuals needing evaluations and receiving outpatient restoration and treatment versus the population at large is something that we'll be able to discuss as a group later on this morning. There was some comments last time about the importance of remote participation. We will absolutely do our best to emphasize that and give everyone a meaningful chance to participate, even if they are not here on site. Again, we'll still be working on the Zoom connection here and hopefully on the volume here in the room. We want to be tough on ideas, soft on people. We want to encourage collaboration, agree to disagree when needed, be curious, be thoughtful, pose interesting questions, challenge each other appropriately. we all know that everyone might represent various or multiple agencies, so when you're speaking, it's important to just identify the hat that you're wearing, so to speak, or please identify the primary organization that you're speaking from, or the primary lens or perspective that you're speaking from. We also talked about, or based on comments and feedback from the previous meeting, we wanted to emphasize keeping the individuals and consumers, clients, individuals and families at the forefront of all recommendations. So, you know, obviously keeping in mind, what are we really doing here and why are we here? We will talk a lot about the scope of the subcommittee. Just a quick reminder about the parking lot. Sometimes things will come up that go slightly beyond the scope of this subcommittee. So we will use those, we will use the parking lot to table some of those ideas and allow us to kind of keep track of, again, what's beyond the scope of this, but maybe what may need to be passed up to another subcommittee or to the larger subcommittee at large, or excuse me, the larger task force. And again, we want to, we as the Farley Center want to serve as a conduit and a liaison between this subcommittee and the task force at large. We also want to recognize interdependencies, and there's a lot of overlap across agencies, organizations, so kind of how to strategically collaborate, how to make sure that we're not duplicating work or redoubling efforts. We at the Farley Center are going to try to maintain awareness of what another subcommittee might be working on, or the task force at large might be working on, that therefore is more appropriate or less appropriate for this subcommittee specifically to work on. But again, please plan to rely on the Farley Center as a resource to sort of help navigate that. We want to be an ambassador to the subcommittee, and now I'm going to look to Emma to remind me of what we mean by that. Basically, I think if there is a concern, if there is any kind of complaint with the subcommittee or what it is that we're working on, please feel free to come to us as the Farley Center and or Summer directly. If you have strong sense of, you know, needing to redirect or change gears, or that we're off target on something, you want to come to us. We would request that you come to us, please, as opposed to speaking publicly about it in your respective home agencies or with the public.
On what we talked about last time of how we're looking to you all to serve as ambassadors, both learning from your community and bringing those perspectives back to this group, and then also sharing updates with your community. So just to strengthen the connection between what's happening outside of the subcommittee.
And then lastly, quickly, I'll just say, you know, we want to stay very solution focused and focus on what is going well in the system and what other aspects of the system we need to improve upon, as opposed to spending so much time. You know, we could be here for a long time, hours and probably weeks, discussing maybe what is wrong with the system and never end up getting anywhere. So we really want to stay focused on what is working and what needs to change in order for things to improve. We will certainly try to start and end on time, logistical considerations notwithstanding, and parking lot, garage doors, and so forth. But we got a little bit behind here this morning, but we think we'll be able to get ourselves caught back up. And as I sort of touched on before, we need to make sure we're using words thoughtfully and respectfully. And again, to reiterate that idea, tough on ideas, soft on people. Additions, changes, comments, concerns, jokes? Summer.
Not related to the group operating agreements, but I just wanted to let you know that Carly Salon from Mental Health Center of Denver is also on the phone as well. So just to let you know she's on there.
Excellent. Thanks, Summer, and welcome, Carly. And with that, I will turn back to Robert and Allison to do a little bit of a review of the time frame.
The the timeline, I just want to remind folks that there's sort of two sections here of this committee. The first section being the plan that you all received. Please make sure you look through it. We will go through this section by section and the meetings that are coming up. But the main timeline is that we have that submitted to the federal court around and about January 2020. Again, we should have most of the plan sort of flushed out pretty fine in its final version by January 2020. We will go through the different intercept sections in here. At the end of each section, there's sort of questions for this group to consider. You can add questions, you can add ideas to them. And then hopefully we will have a pretty final draft in early December, late November. That's the goal. So it gives us a few weeks to sort of tinker with it as a committee. Well, actually, it'll give us 2 meetings as a committee to tinker with it. So really looking for the end of November, early December for that. And then the second half of the year is the idea where we can continue to build on, introduce concepts that will impact competency, but that might fall outside of the sort of the long-term competency plan earlier on, law enforcement interaction early on, other ideas that potentially could reduce the number of people even getting to court, or if the committee wants to go in a different direction, we're open. So in January, we'll probably revisit sort of where we'll move forward with additional ideas to have for the governor's office by June 2020 would be the goal. I don't think we have any more specifics. I mean, those are the key timelines that we're looking at. We will get into the plan in more depth. I know this afternoon we have a small group discussion on what the big issue areas you think this subcommittee needs to focus on. I'm guessing at the next meeting we will, as a group, discuss it in more detail. So make sure you take notes so you can remind yourself, because I know I'll forget in 2 weeks. So, and then we'll start getting into the plan to detail. So, yeah.
I just have one little thing. I just wanted to make sure that people understand really to read the plan. That's literally the document that we're working from that we want to make changes to. And so we need everybody to read it, understand it, and think about when they're reading it, you know, maybe I want to make a tweak here, maybe I want to make a change here. And if it's, you know, things that are going to impact maybe not the plan, but as Robert said, sort of further on competency issues, that's fine to think about them and bring them up, but just please be prepared with the plan, because that's really what we're working from.
Okay, and we'll move on to the next section for a presentation.
I think as long as you keep this kind of pointed towards you, your volume will be good. We'll send a copy of the timeline out to everybody.
Good morning, everyone. I appreciate you taking some time today to talk a little bit about community-based competency. My name is Catherine Davis. I'm the program director for the Outpatient Restoration Program. And I'm here to talk a little bit today about outpatient restoration, how outpatient restoration came into being, what are some of the things that influenced and informed the program itself, the community partnerships that make this program possible, and to give you a picture of what the program looks like today. So the Outpatient Restoration Program was first established with Senate Bill 1712. It made the Office of Behavioral Health the oversight portion of the program. So we establish the providers and provide that oversight to the providers. We establish a certain curriculum that's standardized for both adults and juveniles. We ensure that services are localized, which means services should be in or near someone's community. And most importantly, we leverage the already available services in communities so that we can provide an integrative approach to competency restoration. In early 2018, we established contracts with a handful of provisional providers. And we did that because there were already active outpatient orders, mostly in the Front Range, that we needed to address and we needed to serve. So that was the first thing that we did in the beginning. At the same time, we wrote an RFA, or request for application, so that we could secure providers throughout the state to provide competency restoration services. And we engaged with both the mental health centers as well as private providers and small agencies throughout the state to provide services for competency restoration. To date, 16 of the 17 mental health centers have contracted with the program and are providing services throughout the state at differing levels. The way it looks today is we have services in 84% of the counties in Colorado. So in the diagram, the dark green represents counties that have services that are currently up and running, and they're providing services in those counties. The light green, which you'll notice here at the bottom, those are counties where we have services contracted, but they're not yet up and running. In this particular instance, Montrose, Delta, and Gunnison County, we have a provider who is getting training later this week and will be providing services after that. We also continue to explore options for services for individuals who are outside of the counties that are currently providing services. So for example, in the Northwest region, that is a Mind Springs Health catchment area, and they are a contracted provider and are providing services in some of their counties. And we hope that as they start providing those services, that we're building more services in the other counties that they are serving in their catchment area. Park County is another such instance where we do have the mental health center who is providing services, but they have not yet got them into Park County, and we hope to have that soon. I'm sorry?
Sorry, just a quick question about that map.
Certainly.
Ben Harris with Healthcare Policy and Financing. How does this overlap with the volume of referrals for restoration treatment? So just as an example, are there a lot of referrals in Park County that we should be concerned about?
No.
Or is the vast majority in counties that actually have services?
Thank you. That's a great question. The vast majority of services are taking place along the Front Range and the Western Slope. Denver County, Adams County, Pueblo County, Weldon, Larimer County all have pretty substantial numbers of referrals. We do have referrals out on the Western Slope and in the mountain regions, but nowhere near the numbers that we do in the more populated areas. Yes, ma'am.
Allison Butler from Disability Law Colorado. So I think I missed a little bit of it. I understand the light green, they're about to come online, and a couple of the gray may come online. What about the others?
So right now, I think our largest concern with regards to availability of services is in San Miguel, Hinsdale, and Ouray. That is the bottom half of the 7th Judicial District. We're hoping that we can come to an agreement with the mental health center there, which would help with us provisioning services at that location. Spent some time a few weeks ago with the judges in that area, and they were very, very happy with the fact that we were getting services in Montrose, Delta, and Gunnison County, and felt that that was going to cover probably 95% of any referrals that they did have. Now, that doesn't mean we're not pursuing options for that area. Unfortunately, the Bridges program doesn't have a liaison there as well, and so we're a little at a disadvantage there because we don't have that partner in the community, but they're working hard to get a liaison in that area as well. So the 7th Judicial District is a little bit of a concern with regards to that, but we feel like we're doing a really good job as far as addressing the referrals that they do have. And they don't have a large volume, but we do have a few referrals in that area that we want to address and we want to take care of. Yes, sir.
So July 1st was beginning of this fiscal year for the state. We're finalizing our Office of Behavioral Health goals. One of our goals is to have 100% coverage. So.
Yeah, absolutely. Yes, sir.
Can you talk a little bit, Eagle and Pickens County, that's Vale and Aspen, a lot of people there. Can you talk about what you're doing in those counties?
Well, we're working with Mind Springs to hopefully get some services up and running from their offices. We also have some private providers in those areas that live in Summit, and we're working with them on being willing to travel and provide services in the interim. So we're trying different methods of providing services in those areas. We do have currently a referral from Eagle County, but the person doesn't live in Eagle County. And so we're able to provide services for them because they live in a neighboring county. Yes. Yes, sir.
Rick Martinez. Catherine, I might be getting ahead a little bit. I just want to clarify. When you use the word services contracted, what are you talking about? Because obviously, competency restoration is twofold. I mean, one is an educational program. One is obviously, for many of these people, they need medication management. So
absolutely.
Could you clarify what it is you're contracting to do?
Certainly.
And maybe I'm getting ahead, so I apologize.
That's all right. You are, but that's all right.
Okay.
When we talk about competency restoration services, we're talking about the education component and case management that goes with that. And then I'll get into how we're fulfilling the best practices to provide all the services as well.
So these are not contracts specifically for mental health centers to be providing medication management of people who need medication management?
No, these contracts are specifically for the competency restoration education.
The educational piece.
Yes.
Okay, thank you.
And I'll get there, I promise.
And so the barriers for, it looks like probably half of what the problem areas are in Mind Springs territory. Is the barrier Mind Springs, or is it the counties, or?
No, not at all.
What do you need in order to be successful in those areas?
Not at all. It is getting services up and running and then getting more of their staff in those areas trained. They just currently don't have staff in those areas trained. So we're working with them on that. They're not the problem by any means.
So is there anything that could be done to accelerate that process?
I think it's just a matter of them hiring and getting the services up and running in their program. It's new to all of the mental health centers to provide these services. And so each one is taking differing amounts of times to get up and running with them. It's a new population for them in many ways, but at the same time it's not. And so I think it's learning that as well, that lends itself to them growing that program within their services. Yes, sir.
Catherine, I'm sorry to belabor this graph, but I think it would be interesting to see this graph at some point, just looking at referrals per clinicians in all these counties, because I think right now, I think we automatically go to these gray areas, and I wonder if there are counties that are just, their services are there, but they're understaffed, and so for the volume of referrals that are going there, they're almost would be more problematic coming in the future. And if we think about our task as a subcommittee, but to really look at how do we actually complete these referrals, complete these processes, it actually may be a different story if we look at referrals to provider for the county.
And we'd be happy to provide that.
I do know, I think the whole Western Slope is about 8% of all the referrals. I think it's something like that. Just to put in context, but the total number of referrals, I don't know off the top of my head, but.
Yeah, and I just wonder though, if the real problem may be actually on the front range where it looks nice and green and healthy, but we actually don't have enough providers there and the vast majority of the referrals there. And so right now this looks like the Western Slope is a problematic area, but it actually could be somewhere in a different part of the state where, you know, there's one provider for, I don't know, making this up, 200 referrals, which doesn't sound like a great situation. So.
Right.
That was some of the questions I had in reading the plan as well. This is Moses Gurr, is just what CDHS intends by getting 100% coverage, and whether that just means having contracted providers physically located everywhere, or just having other types of, like Ben was getting to, ratios of referrals to clinicians or what. So I think that's just a conversation to flesh out.
I think our first goal is just to get coverage everywhere, and then our second goal would be capacity. As far as we are tracking the number of community-based referrals and how long, if we're able to serve all the referrals. I mean, that's something we keep track of and we monitor, because one of our other goals this year is to increase our ability to provide outpatient services by 10%. Well, a little under 10%, but yeah. I should add, outpatient restoration is about 28% right now. Our goal is to get it closer to 38% of all referrals. So meaning that, so basically right now, 72% of our referrals are for inpatient beds, whether it be at the RISE program with Arapahoe County or at one of our hospitals.
Thank you. So with regards to our education program, one of our tasks was to provide standardized education for both adults and juveniles. So when we originated the program, at that time, CMHIP, or the Colorado Mental Health Institute in Pueblo, was using the Florida State Comp Kit for their curriculum. And we adopted that as our adult curriculum moving forward with this program. For juvenile curriculum, we adopted the Utah State Juvenile Curriculum. Both curriculums were revised and we made sure that it reflected Colorado statute and the needs of our program. The adult curriculum underwent a full revision, and we reorganized that curriculum. We also added more provider tools, and we beefed up the participant manual in their workbook so that they had something that they were working with that was a little bit more substantial. Now, in those curriculums, there's two major areas that we address. We address factual legal knowledge, and those are things such as the roles of the people in the courtroom, evidence, what a felony and misdemeanor are. We make sure that people understand what pleas are and plea bargains are. And all of this is to make sure that individuals who are going through the competency restoration education have a firm understanding of how a courtroom works, okay? We do this by using activities, we use video resources, there's role-playing, group type of interventions. So there's a lot of different ways that our educators use the curriculum and use the tools that we have within the curriculum to help people understand the factual legal knowledge. The other side of that is the rational understanding. So some of the things that our participants will do is they will work with their educators to learn decision-making skills. And another side of that is that our educators will engage with the participant to determine whether or not they have a rational understanding of what is going on, and whether or not they have that ability, that present ability to be able to interact with their attorney appropriately, as well as the ability to understand the proceedings. And we do this through using a lot of scenarios and storylines to help with that rational understanding piece and learning decision-making skills. And then that way, people can demonstrate that knowledge as they're learning these skills. It won't move forward. Well, that's keeping, maybe, okay. Another thing that we've worked really hard as we've developed this program is engaging stakeholders. And we've done this through presentations, we've done lunch and learns, we have conducted webinars and one-on-one meetings all over the state so that we can not only inform our stakeholders of what we're doing, but more importantly, to get information from them, to help them inform us as to what the program needs to look like and what their needs are in their areas. And that's been really, really helpful as we've been moving forward, because as we've been building this program, we've learned a lot about the differences in different areas of Colorado and what the needs are. And it's been really helpful for us to learn and understand that so that we can make the program work for everyone. So the other thing that informed how we developed the program was the best practices model. And this was put out in 2012 by the National Judicial College. And what this does is it put out guidelines for competency restoration. But for community restoration specifically, there were 4 areas that the National Judicial College outlined that should be present in the community in order to do competency restoration. The first area is to make sure that there is a treatment program that is available to these individuals that can meet their specific needs. And so that's where the partnerships with the mental health centers and private providers as well as small agencies has been really, really helpful in doing. We also have to provide that intensive individualized training, that education piece. The defendant should have a stable living environment with people who are supportive of their efforts in competency restoration. And if the person is engaging in substance use, that they're willing to try to abstain or receive services for that. And the defendant really does need to be willing to engage in these services. So how do we do that? So the first thing that we do is we make sure, I'm sorry. Yes. My question is.
Sorry to interrupt you.
Oh, that's all right.
My question is, when the evaluators are recommending community-based restoration, are these the 4 criteria they're looking at and recommending whether someone should be restored in the community?
No, what they are doing is they are recommending it as long as this is in place. So, and I'll get to that as far as how that information comes about. But they are recommending community-based if the services are available for that person in their community. Yes, ma'am.
This is Allison again. So if a person is homeless, are they not going to be eligible for?
Not necessarily, because it depends on each individual. We have some communities that really have a wonderful amount of services and support for the homeless. And we've had people who are homeless in our program who have been successful and who've been able to engage in the program. And that comes a little bit later, but I'll explain a little bit how the courts are informed of that and how they know that before making a decision to competency. Yes.
And I think it's important for this group because that's one of the biggest barriers is getting judges comfortable with residency, people who have a lack of residency stability in ordering outpatient referrals. We did a sample between October last year and end of November, really 2 to 2.5 months into December. And we found that roughly 17% of the individuals that were admitted to the hospital or RISE didn't need a hospital level of care, and their charges were misdemeanors, petty offenses, low-level felonies. So these are pretty small, minor crimes that the general public would never be locked up for. So there's a substantial number of individuals that are being court-ordered into a hospital bed that's taking up someone who needs a hospital bed, and that's why we're trying to turn into more of the community-based restoration, so we can get those folks, one, that are not in a restricted setting, and 2, we can free up hospital beds for folks that need it.
This is Ben with HICPUF. So this maybe could we, or the question would be, is what are those barriers or misconceptions around differentiating a person who needs to go into inpatient versus community-based treatment? What I'm hearing is there's just educational opportunities within the judicial system around what is maybe appropriate. And then there's also housing concerns, supportive housing concerns. What are some other barriers that kind of play into a role of putting a person into inpatient restoration services versus community services?
Okay, so I can talk in general terms, but this is very individualized. Each individual and where they're at, it makes a difference. But if you have someone who meets a hospital level of care who is of danger of harming themselves or someone else, or who is gravely disabled, which is the 2765 criteria, that person should be in a hospital setting, at least initially. Someone who is going to suffer some negative consequence that we can see should be in a hospital setting. We should always consider outpatient first and why we wouldn't put someone in outpatient, rather than thinking everybody should go to the hospital and then someone needs to talk us out of why they need to go to the hospital. Okay, and that's how it's been done for so long. We're trying to really shift that paradigm. And each individual is going to be different because each individual comes from a different community, has a different level of acuity with whatever their barrier is. And so we really need to stop and look at that. And I'm going to talk a little bit about how we do that with our partners to provide even more information to the courts to be able to make a good decision around that.
And respectfully, although clearly a component of it is educating the judges, and I'm chair of the Mental Health Education Subcommittee of the Judicial Education Committee for the State Judicial, and that's something which is a real priority. But I don't see that as being the biggest barrier with the bench. The biggest barrier with the bench is the fact that here you are supposed to be having some level of monitoring and ensuring that these services exist. And on paper, it looks great, but as a practical reality, I have to wonder whether or not you have the resources to be able to provide that level of service to make sure that if there are barriers such as housing that become a problem, who's actually going to be addressing those kinds of concerns. And from the bench perspective, if we don't have a good level of confidence that we're doing better than just setting this person up for bigger problems, that's where we get stuck. And it's not that we want to hospitalize people, we want to make sure people are safe.
Yeah, and we acknowledged that, I don't know how long ago, but I met with the chief judge in Denver and other judges in Denver to ask that exact question. What do they need to feel more comfortable in referring outpatient? So we're going to do a pilot with Denver because they're our highest referral sources, and they have, a lot of them are they're lower percentages on community-based restoration as well. So we're doing a joint pilot with Mental Health Center of Denver. But the key is pretrial supervision in Denver is part of the pilot. So we gave them funding to hire and train up a mental health person who have a caseload of 22 people on their list, and they'll do the pretrial supervision part because we're not really equipped to do the supervision part to the intensity that pretrial does. Part of the gap is not every judicial district has pretrial. I know that's a bill that's been floated a couple of times. So we are piloting with Denver for that exact reason, because we need the judges to feel comfortable with the level of supervision and services, and pretrial will help address the housing in the local communities, where the clinicians on the restoration side, it's not necessarily their forte.
Thank you.
We have one question from Zoom, wondering about the process to evaluate sites providing services.
I'm sorry?
Is there a process to evaluate the sites that are providing the restoration services?
Process to evaluate. Oh, you mean like an auditing process? Mm-hmm. Yes, we have developed an auditing process. I'm sorry, yes, we have developed an auditing process. And I can talk to whomever that is offline more about it if they'd like. Yeah, yeah. So again, how do we provide these services and meet that level that the National Judicial College puts out there as far as service level? So first of all, we educate all of our service providers with competency restoration education, all 47. So currently we have 47 providers across the state. We also make available to them case management dollars. So if they recognize the barrier that needs to be addressed outside of what they're doing, they're able to take that time to work to make sure that that person gets connected to those services. And so those case management dollars are available to all of our providers. But we've also contracted with a lot of providers that have in-house services that meet the needs of individuals with competency issues, such as social and supportive services for individuals with intellectual and developmental disabilities. We also have more intensive services available through many of the mental health centers and small agencies, including psychiatry, counseling, peer support groups, targeted case management, and ACT teams to help out with that. So,
just on that last slide, can you talk a little bit more about the supports for people with IDD?
Yes. So early on, we partnered with Alliance Colorado when we were trying to find service providers who were specialized in IDD. We did a webinar, and we had a few of those service providers engage with us with regards to providing services. An example is Strive in Grand Junction. So anytime we have a referral where somebody has an intellectual developmental disability, if we have a provider who has that focus, we're always going to send them to that person. And I'll talk a little bit more about that later on. I would like to engage more with that community. I think it would behoove this program to be able to have more service providers, because again, the idea is not just to get this person through competency education. It's about connecting them to the appropriate resources in their community so that we can hopefully get them out of the criminal justice system. And so they're properly supported by the agencies and the people who need to be supporting them. So when we send somebody to Strive, we send them there with the idea that if they're not already engaged with Strive, they need to be engaged with Strive. And that's how we look at those referrals. Welcome. So it's our partnerships that really make this work, quite honestly, because some of the issues around stable housing and accountability and really cultivating those natural support systems, those come from on-the-ground work that we can't provide out of our office. And so we work with the mental health centers, we work with our providers around that, but we also work with the Bridges Liaison Program and pretrial services in areas where pretrial services is available. And they're able to help us kind of tie everything together with regards to making sure that individuals are getting the services that they need. So let me talk a little bit about the Bridges Partnership, because this is a really important piece of outpatient restoration as well as competency across the board. So the way that the Bridges program supports outpatient restoration is ideally you have a liaison that is court ordered to a case at the time that competency is raised, or even before, but ideally at the time that competency is raised. And what that liaison does immediately is they perform several measures with this individual. They meet with that individual face to face, and they're looking for indicated need. What are the needs of this individual, and what can I do to connect them with services now? Not wait until after a ruling has been made on competency, but now. And so they work really hard to try to engage that person. They're keeping an eye on them. They're trying to make sure that their housing is stable. They're looking to make sure that if there's an issue with food, that they get them connected, and they make sure that they are working with the food bank. It could be that they need to get back on medication, and so they're engaging with psychiatry early on, if at all possible. Now, what they do with that information is they provide a report to the court prior to the hearing that makes the decision on competency. And that report will outline the needs of that individual, the indicated needs, what services that individual may be engaging in already, and can the community support that person getting their competency needs met in the community. And so that's what I mean by that individualized piece, is that those liaisons are able to provide an individualized snapshot to the court and say, here are the needs of this individual, and here's how those needs can be met in this community. And so they're going to advocate, when appropriate, for community resources first, okay? And then they continue to follow that person throughout that competency journey. Okay, so there's somebody who is keeping a pulse on what's going on. Now, the Bridges program is just now launching, okay? And they have not gone statewide, but I've been working with some of the liaisons already, and the amount of work that they're doing to make sure that these individuals are getting what they need is astonishing. And I'm really excited as this program comes online, what they're going to be able to do to shift this whole idea of whether or not the community is the best place for competency restoration. Yes, ma'am.
So who has responsibility for the Bridges partnership? Is that DHS or
No.
court pretrial services?
No, that's food judicial. And the, do you want to speak to it, Jonathan? You're on the steering committee as well.
On the steering committee, it is directly part of state judicial. I think the anticipation is each judicial district will define how they're going to use the Bridges coordinator, but that's something that our group can have a really strong impact in making recommendations as to how to leverage that resource to serve the interest of people who are engaged in competency services.
Yes, ma'am.
Two things I would love for you to follow up on. One is, how are the Bridges folks coordinating with the forensic support teams, or what's the differences there?
Mm-hmm.
And where are we on the confidentiality issue? I know that there were some concerns about the Bridges folks possibly getting confidential information that maybe
Right.
attorneys want to go to the court.
Now, we have two people here who are on that subcommittee for the Bridges, so I'll let them speak to that in a moment. But with regards to the forensic support team, okay, so the forensic support team really is going to mirror on the side of CDHS that connection to services. They're the one that are going to tie together all of the activities that are happening on the CDHS side. Now, I say that knowing and looking here at my boss that it hasn't been fully developed yet because we're still hiring staff right now. Okay, but the idea is that they're not going to be doing the same work that the Bridges liaisons are going to be doing. They're going to be complementing that work. And what I see, just doing the work myself, is that when something happens on the court side that they need to make sure that we're aware of, they're not going to my program directly, they're not going to RISE directly, they're not going to court services directly, they're going to the forensic support team. And they are going to be the information brokers for CDHS. And they're the ones that are going to be connecting people, they're the ones that are going to be helping move people to appropriate levels of care. They're the ones that are going to be communicating with the liaisons so that the courts are aware of exactly where someone is, exactly what they need, and so that we can get the services delivered in the appropriate place at the appropriate time. So now with regards to the confidentiality piece, Judge Seamus and Lucy, you guys are on that committee and I have not been there, and I know it's a grudge match. So if you guys would speak to that, it is an important issue.
I'm a public defender and I sit on the steering committee for the Bridges Committee, for the Bridges program. From my perspective, and I think I'm speaking for the group that are working on this, the issues of confidentiality aren't very well implicated in the competency context, because there's a statute that waives largely confidentiality and provides protections to people who are in the competency process. And so the real challenge and battle right now is over those folks who are in the Bridges program who aren't in the context of a competency process. So I don't think it's a large challenge for us, at least. I am a little concerned because there are specific types of items and information that can be shared through the competency process, and the Bridges liaison may be collecting additional information that's not specifically outlined in statute. And so that's certainly something I think we could build some protections in, but we're talking about sort of less concerning information about our clients than might than the true mental health issues, which are in fact disclosed as a part of the competency process. And then the one other challenge is when competency is raised by the court or the prosecutor doesn't get access to the information about doesn't get the evaluation unless the defendant is found incompetent. And so there's that very narrow population where the court or the DA have successfully raised competency. We need to think about how to protect those defendants from their information being received by the prosecutor, unless the court in fact does, upon evaluation, find them incompetent.
It shouldn't be that narrow. It's really the competency right now in Colorado, I think it's about 40 to 45% of people are found competent in the evaluation. About 45%? No, found competent. So I know, Rick, I don't know if you have more to add to that, if you know, but special masters, I said, even that's kind of low. It should be closer to half and half, or closer to 60-40 the other way than what we have it right now. But maybe we should set up a meeting to talk about privacy, because it's not the only area. And Stephanie, if you can maybe put something down, if you want to email me, because DYS has the same issue, youth corrections has the same issues in detention with social workers who want to start or giving some treatment to the youth that are being detained, but their lawyers are worried about what can be disclosed, what can't be disclosed, based on that. And then we just ran into this issue last week with jail-based services. So OBH does contract with jails that want to participate in providing funding for substance use treatment, but also funding for mental health services as part of the settlement, mental health services as well through jail-based behavioral health services. But a lot of the jails have said they're not clear what privacy they can do in the screening process. So there's 3 screeners that they go through, and they're concerned about confidentiality as well and what can be disclosed in court for what they screen for. So we're waiving that component for the time being, but that's like the critical component of jail-based services, is to do the initial screening for needs. So it seems like there's multiple areas here related to mental health intervention in jails and other areas where confidentiality, we might need to look at the statutes and see. I'd hate to hold up the ability for jails to screen for services that are needed because they're worried about what could be divulged in court. So maybe we can, because that's not really competency, it's a bigger issue. So maybe we can set up a time. If you guys are interested, anybody that's interested can email me and participate in that, and we could talk a little bit. This came up in our last monthly meeting with Special Masters, who is the federally court-appointed expert to oversee this process for us. Anyway, so please email me if you guys are interested in talking more about this, because this is not the only area where the confidentiality is an issue.
Thank you.
Yeah, no, I was going to say, strictly speaking from a judicial perspective, it's not that complicated an issue in terms of, in the interest of protecting the person's privacy and also to encourage full disclosure and participation. My preference is to do as much as possible to protect confidentiality. I know that the Office of the Public Defender and Office of Alternate Defense Counsel are working on proposed confidentiality orders. That probably needs to be done with CDAC as well, to make sure that all interests are represented in whatever is ultimately approved. But there's a whole area that I think is really needs to be discussed, which is before it even gets to the courtroom, what needs to be done to protect the assessments and what can be done. And I think that's got to probably ultimately be a legislative fix.
So maybe set a separate meeting. Could CDHS be invited to potentially some of those conversations, and just let me know when they are, because youth corrections in both jail-based services are under CDHS.
Sure.
Thank you. So to give you an idea of on the ground what outpatient restoration looks like. So our program, one of the things that we do is we manage every single court order for outpatient restoration that is ordered throughout the state. And we manage those referrals. We manage all of the billing for services because the services are paid for through CDHS. We house all the reporting, we gather all the data, and we track capacity as well of our providers. We also do oversight with our providers, including initiating the contracts, the training, the auditing, the relationships with the clients, and we also conduct a learning community that meets every quarter, made up of all of our providers, and we talk about different topics having to do with competency restoration, including introducing and talking about new tools and ways to work with individuals with competency problems. We also do outreach, and we've worked really hard with this, outreach and training with courts, with legislative task force, with anybody who will listen to us, quite honestly, because we really want people to understand that this program is out there. We never want somebody to be ordered to a level of care that they don't need because they're not aware that this level of care exists. So how we do these referrals, and just to give you an idea of how that process works, when we receive a referral from the court, we have an internal kind of timeline that we work with. We want to turn that referral around within 48 hours, okay? And within 48 hours, what we do is we first look to see if there is a provider in the geographic location of where that individual lives, okay? And then we study that individual's information and try to determine from what we have, what are the needs of that individual? Do they need the high intensity wraparound services? Do they need to go to the mental health center for those services? Are they already engaged with a provider and we just want to support that engagement and make sure that the referral goes to that provider? So we're looking at that throughout, and we're looking at the acuity of that individual, what their needs are. Okay, and then that way what it does is it gives us the ability of fulfilling that best practice of making sure that people are getting their needs met at the right place with the right level of services in the least restrictive setting. So to give you an idea of the scope
Catherine,
of the
can I
program
ask a quick question? Sorry.
Yes, sir.
If you go back to the slide.
Sure.
So with service needs, you said there's a question of, you often say, you know, is there engagement already? What percentage of the referrals have you seen thus far already have community-based engagement?
I would say it's a pretty small amount, but as the Bridges program comes online, I think that's going to raise a great deal because they're going to be engaging people with the intention of getting them engaged in services prior to competency even being ruled on.
Because I just wonder, as a subcommittee, as we think of part 2 of our charge of where do we want to make kind of forward-thinking impact, it would be interesting to see if these individuals are already engaged and, you know, where are they being engaged, why are they being engaged before they even come into our system, the criminal justice system period. So it would be interesting to maybe report back on that.
I would say they're probably not engaged in services, and that's why they're in the criminal justice system, or not engaged to the level that they need to be.
Yeah, and distinction, not engaged doesn't mean they haven't been referred to a private clinic, to a prior clinician or a mental health center previously, right? So I think you're right. That's sort of something we have to discuss here. Were there missed opportunities before the contact with law enforcement or being arrested? Missed opportunities meaning that are there certain statutes, are there certain resources, is there a certain process in place that's missing to help sort of make sure that folks get fully engaged before we get to this point?
Thank you. I'm getting a little antsy. I got to get back from behind there. So to give you a little bit of an idea of the scope of the program currently, in our first full fiscal year, we were originally projected to work with 260 people, okay? In our first full fiscal year, which just ended June 30th, we ended with 689 adults and juveniles that we have processed referrals and have had active in our program during that fiscal year. So the need is there, okay? We know the need is there. We also know that we have to continually expand these services. There's a lot of things that we would love to be able to do right now that we're not. There's a lot of direction that we've been looking towards, such as working with the IDD service providers a little bit more closely. I would love to get more on board with regards to service provision. So there's a lot that we can do moving forward, but just to know that this ship was being built while we were sailing it and continues to be built. And that's one thing I want to really encourage everybody is, you know, the feedback and the ideas that we get from you are important. And that's why I'm here today, is I really want to get that feedback. I want all of you to understand what it is that we do. And then let us know what you think would be helpful with regards to building this program in a meaningful way. Okay? Yes, sir.
Hi, Catherine. First of all, let me just say, this is wonderful what you guys have been doing. So I want to first give some praise for this program, what's been happening in the last year, because I'm familiar with some of it. Let me tell you where I'm struggling a little bit right now. Part of it's conceptual. You use the term restore competency. And if I'm hearing you right, you're mostly emphasizing the educational component. I'm going to go back to the medication issue because I'm concerned about this. Because if you look nationally, 70% or more of people who need restoration, most people think that the major issue is getting medication on board. The vast majority of these people have diagnoses of major mental disorders like schizophrenia and bipolar disorder. And then subset, of course, is those with intellectual disabilities and developmental disabilities. So my only concern, even conceptually, when you put up your triangle, you had the educational piece as sort of the foundation, and I appreciate that. But what I don't want this group to be misled on is the idea that if we do an educational restoration program that's across the state, it solves a competency problem. And that's why my first question, and I really want to tease that out a little bit, the issue of medication. In these contracts with these providers, is there a carrot or a stick to make sure that people are getting on medication? Because medication is going to be core to efficient restoration of competency. You can do all the education in the world. If you don't have someone on the medication, that might be a reason they need to be in a hospital. So if we don't address the medication issue first, for a lot of these people. And since I literally supervise hundreds of these restorations, competency evals every year, I mean, that's the main problem we see. People coming in who are not getting good community mental health center follow-up, or they're having trouble accessing a provider, a psychiatrist, or a mid-level provider to get them on the medication they need. So I just want to stress that, maybe have a little comment. And Robert, you may know more about this.
Okay, thank you. Well, I don't know about carrots and sticks, but the way I see it and the way that we've envisioned it is that the educational piece is really the foundation. It's not the end all to be all. It absolutely is not going to solve the problem, and I agree with that. That's why whenever we're making referrals and we see that somebody has maybe a diagnosis of a mental illness that we know is indicated for medication, we're sending them to the mental health centers. And the reason we're doing that is part of the mental health centers process is that they're doing a full evaluation of that individual. In some cases, they're already engaged with that individual. Okay, so they're known and they know what their needs are, and they have a relationship with them. And medication I see is it's not necessarily black and white, yes or no. Sometimes it takes that time of building a relationship with a provider and trust to be willing to go down that path for some. Okay, but in the community setting, we feel like if we can get the person to the appropriate provider who can provide those types of services in-house, then we absolutely have the best chance of getting them to a place where they're willing to take medication. And I agree with you. There are some individuals who need medication, who are unwilling to do it, and they meet that hospital level of care. Okay.
Well, I'm not going to go to the hospital
yeah,
for care. I mean,
I know, and I know you're not, but we also know that that happens. We also have those case management dollars available because sometimes someone will go into the system and we don't have a lot of information on them. And it isn't until that education provider starts engaging with them that they realize that there may be other things going on that they're not aware of. Okay, and then that's when they are using those case management dollars to connect them with the resources that they need and get them connected to medication provider, counselor, substance use counselor, those types of things. So I don't know if that answers your question, but that's the vision that we have, is that the education really is the foundation, but we also know that all these other things have to be in place, and we're working hard to make sure that our providers are making that happen. Bridges is also very well aware of that, and they're trying to make it happen. And so a lot of effort is going into trying to get people the level of care and the services that they need.
So can you guys put on the agenda maybe 15 minutes the next meeting? I could talk about the Denver pilot for community-based restoration. I agree, Rick. I think, and it's funny, I wrote a note to Allison, like, this really should be a package. It's not. It should be a package that kind of, and that's what we're testing out in Denver, is this package component. We are in our sort of contract with Mental Health Center of Denver, getting a guarantee of psychiatric time for medication. Nationally, there's there's a model called assertive community treatment, right? And it's for anybody in the community. Mental health centers, most of mental health centers they do some version of it, and I'm a big fan of it. I do think that's where we need to go when we're talking about providing intensive services in the community. And it's the idea that there's an intense wrap around the individual in the community. There's a lot of case management. It's been one of the biggest barriers to community restoration is that psychiatric component has not been all one package to the court to consider whether to bond someone out or not. And I'm wondering, actually, I'm pretty confident that we'll revisit that here. And I'd like the committee to revisit that here. I'd like to see us move that forward in a more structured way that's more definitive than it is today. There's no guarantee that you're going to get that package when you're referred to community-based restoration. So I just throw that out there. I'll talk more about maybe 15 minutes the next one, but I completely agree with Dr. Martinez that that's part of the reluctance. The part of the reluctance is I don't know what psychiatric care. You tell me education and restoration. I'm not fully sure what that means on the psychiatric care side of the shop. It really needs to be one. So one thing I will commit, maybe we'll talk a little bit more about it here, and then I'll be happy to bring that to the safety net subcommittee, because I do think that is the responsibility of the state from a safety net component for this population to make sure that they're getting all their services in one package. I would love to see pretrial services be required for this population. That'd be a legislative change, because the supervision component is really shouldn't fall on the clinician. They're not that effective at it. And then the quality pretrial services are really connected well with the housing components and the residential programs in the community. At least in Denver, it seems like they are much so better than OBH or the clinicians. They really seem to know. Now, the mental health centers know a lot of the residency programs as well, but pretrial seems to be really on it. I would like to see pretrial required for this population, a community package. I think that's a big component why people are not going to the community, is that supervision component with housing component, as you mentioned, the judge mentioned earlier. I know I'm throwing a lot out there. We'll revisit it again and go through it again. But I do think that's one thing when we get to the intercept model, that I'd like this committee to talk a little bit more about what community restoration should look like, and who should we require to be at the table. One thing, folks that know me, I'm not shy about saying who should be required to be at the table, because OBH can't do it by ourselves, and we shouldn't.
If I can just follow real quick, I just wanted to stress, appreciate that, Robert, what you were saying. I just don't want this group who's got this task to be under the misconception that when we're using the word competency restoration, if we're just talking about an educational model, we're missing the boat phenomenologically on what's in the community. And that's why I throw the statistics out. I mean, the vast majority of these people have serious mental illness. They have major mental illness. And the major bar often, at least historically, nationally as well as in Colorado, has been the lack of medication engagement. I'm not saying involuntarily, even voluntarily, just the lack of providers who are willing to see these people to some degree. And I don't need to go into the history about conflicts with the community mental health centers and their role in this, but I just want to make sure we don't lose sight of the fact that we have to, I think of competency restoration as a package of services. Psychiatric and medication services in 70% of these people is central. You can't do education with someone who's delusional. And we know that from Pueblo. I mean, the people come to Pueblo who are hospitalized for incompetent to proceed. They don't even start the educational program a lot of times until they've been in the hospital a couple of weeks and they've been medicated, and therefore some of their rationality is restored and they can even engage in the educational piece. So just clarification of concepts, but
I agree. I agree with your concept, but restoration itself is the education component, but it's not, I agree it's not going to work without the psychiatric care. So that's why they need to come together and be one. As far as community-based, I think the challenge we have to look at is capacity, right? The ability for a psychiatrist to see someone really quick as soon as they're arrested and getting that started right away, even before you get to court, if you can get that started. I think it's something we need to look at. I think that's where telepsychiatry comes in, using sort of different other technology. We're never going to get to a place where we have enough psychiatrists to be available in all judicial districts at a sort of a day or two's moment's notice, and have time on their schedule to see someone. So I think those are all the things that we should think about here.
I also want to mention that this isn't just for outpatient. I do think we have to, as a committee, be thinking about where does medication come in also for folks who have to go inpatient. A lot of that 70%, if they do just get stabilized on medication, may not even be incompetent. So we may not be going through this whole competency process. We may not be taking up a bed at RISE or at CMHIP. So I think figuring out how we can get psychiatric services involved as soon as possible, whether it's inpatient or outpatient, is definitely a task for this group. Yes, sir.
I just wondered if you could shed a little bit more light. It seems like, this is a fairly new program, right? You set it up. I think it'd be really interesting to me to know a little bit more from a data perspective, how long it takes folks to be restored to competency while in the community. You all have served, you put out a couple of numbers here, but I think it could be helpful for us in thinking about the barriers one of the things that I'm struck by is that despite the fact that you all have set up this program, the people who are waiting in inpatient settings or in jail for beds to be restored are still going up, right? So if this, you know, and as a person who's very familiar with Medicaid, and the standard in Medicaid is least restrictive service, least restrictive setting for a lot of these folks. What is the, you know, how do we make sure that outpatient restoration is even more successful if we think that this is really a way for us to solve the sort of bed crisis that this competency conversation is really all about?
Thank you. As far as data is concerned, we're just finishing up our first year. And so we have very little data. We have the data in-house. We're working on getting that data reported out. So hopefully we'll have some over the next month or so, and we'll report that out to you, including information with regards to capacity, because we do have a few capacity issues along the Front Range. I'm sorry, what was the last part of your question?
I think it was mostly around the idea that we really haven't. I'm struck by the fact that despite the number of competency restorations you all have done, that we haven't seen a decrease in the number of people waiting. You know, the data that they've showed us in this is kind of striking, and then it continues to go up.
Right.
So how do we make, you know, and this is the question maybe for our group better, is if we think that that outpatient services are appropriate for a large number of folks, how do we make sure that these folks are more successful? I don't know that I have the answer to that question, but it strikes me that we need to be doing something more than what you all are already doing in order for you all to take some of the burden off of the inpatient side.
Well, and I agree, and I don't have an answer for you. I could give you an opinion, but I'm not. But I think that part of it is the fact that we have started this. You know, it was just over a year ago that we didn't have an outpatient restoration program. And Dorinda and I walked through the door at the end of March in 2018. So that's how new this program is. But from the numbers that we've experienced already, we know that the need is there. And yes, numbers are growing across the board. And so I think we're doing a little bit of catch up. But I think what we're also doing is we're learning a lot, and we're looking for different ways and different avenues to be able to deliver services so that more and more people can come to the outpatient setting, or I think in a perfect world, who may start in an inpatient setting and get transferred into an outpatient setting appropriately. So we're looking at that as well. So there's a lot of opportunity there, and that's not lost on any of us. And those are things that all of you can help inform us of moving forward. So I just want to invite you guys, if anyone has questions, or you're very welcome to contact me. I would also really encourage you to go to the Forensic Services website on the colorado.gov website. You can get information on this program, including downloadable fact sheets and brochures. You can also see my little map and how it changes. But you can also get information on other forensic services programs that address competency on that website. So I'd encourage you to go there if you haven't already. Yes, sir.
Hi, Derek Harvey. I've just got one question. Earlier you mentioned that if somebody is a 2765, danger to themselves or others, that's still appropriate for inpatient care. And the community restoration best practice model doesn't really discuss that individual's proclivity for violence. So is there how would you envision that triage of the 689 individuals to defer them to some sort of community-based services without, would there be an evaluation of whether or not they could potentially have some sort of violence if they're in a community setting?
My understanding is that our evaluators don't evaluate for that, but maybe Dr. Werthwein can give you more information on that as far as the evaluation for propensity to violence.
I don't know if I have an answer. I know it's discussed pretty widely in court, but I don't know if I have, I mean, I'm probably not the right one.
Well, my understanding is that that's not something that our evaluators do. We do have a triage program that we're rolling out right now with regards to other things, but not specifically to that, because it's my understanding that the evaluators who evaluate for competency do not evaluate for that.
I think it's really important that that's part of our conversation, is how to effectively assess that, because to put any judicial officer in a predicament where we're just out of the blue coming up with that assessment on our own is really not appropriate for the community or for that individual. So I think it's really, really critical for our conversation. The second thing is with respect to what you were talking about not having the clinician be the monitoring entity, spot on. Should be pretrial services, but I think a part of our conversation with that issue as well needs to be the justice system is designed to have a response if there isn't compliance, and to try to develop a broader system as to if someone is delusional and they're not cooperating, what is the effective judicial intervention to engage with that person? And that's a conversation I think that we probably can make some effective recommendations. Third thing is, in terms of your office, it just seems that the demand that's being placed on it is just so great. Is it realistic to expect you, without having additional resources, to be effective in performing what we're tasking you all to do?
So I'll take that one if you want, but the answer is, Catherine is currently looking at her research because she is under-resourced. So we're looking at what we're legislatively required to do. They are under-resourced. They did not anticipate the number of referrals we get, with there still being others that potentially could be referred to your last course. So resources are absolutely a question as well to keep up to speed, but also to build a program that judges are going to be more comfortable. I think we need more resources. I think judicial districts need more resources around pretrial. I wonder if pretrial can help with sort of the, I want to be careful, I'm too bad Dr. Martinez left, but about the clinician getting into potentially aggressive behaviors versus non-aggressive behaviors. Well, on the clinical side, I see that's the court's charge as far as public safety component there. So maybe it is pretrial. I mean, if we are mandating pretrial to come to the table, if we get there. Yep.
Pretrial exists, one.
Yep.
Two, that they have the tools they need to be able to properly monitor the others, and if it's not being effective, then what's the appropriate intervention?
I agree. We should flush all that out. And I think that's all on the table. So we feel like pretrial and all that is a key component to what's missing. Then if we're going to mandate it, then obviously we have to ask for resources to come with it. But I wonder if they're the group, it's your aggression question, if they're the group that can assess for a public safety component there.
And they may be, I don't know, but somebody could be able to provide some insight.
Yeah, I agree. I think you're going to get a big pushback from clinicians, and I kind of agree with them on this one. It might be outside their clinical scope to assess. I don't know, Dr. Rai, you want to make a comment?
So I can talk from the jail's perspective. Like when people are in the jail, they are classified as level 1 through 5 depending on their violence level. So they are in separate pods because of that. So if the judges were talking to the sheriffs and getting that data from the jail, because we know when there's an incident of violence in the jail, when somebody is assaulting officers and they're assaulting other inmates, when they're threatening people, when not following rules of the jail, we classify them and then we kind of move them accordingly. So they'll be, for example, in Denver, they'll be in a pod like 2D where they're there. They break the rules of violence, but they don't share that information. So I think information sharing should be important. And so I think there is already that data, but it's just not being shared. So I think the sheriff sharing it with the judicial district as well as with the clinicians would be helpful. But because the sheriffs have their own data system, it's different. I mean, not everybody has access to that part. And to Allison's point, I think it'd be helpful when competency is raised that the jail-based mental health services already goes and sees people, sees them and sees whether they need to be on meds immediately, so that by the time the evaluator comes within those 30 days, they're already stable enough that they pass the evaluation. We've done that in some parts in Denver where we actually go and see the person beforehand and say, okay, this person needs to be on the meds already, and then we'll do proactive stuff. I think the problem that we face in the jail is our hands are tied. If I go and see someone and they're not taking meds and I think they need meds, I can't do a lot for them. In Denver, I can do some kind of involuntary treatment, but once they leave the jail, they will stop taking the meds and they'll relapse and come back into jail. So a lot of my people who are, come back to jail again and again are the same people who I automatically know that they leave the jail, they'll stop taking the meds, they'll relapse, they'll pick up a criminal offense, and they'll come back to jail. And I'm unable to transfer that certification to the outpatient, or if it's a separate criminal commitment, involuntary med or process, I cannot transfer it to outpatient process. And so I know that that person is not going to comply with treatment and then come back to jail again. So those are a couple of things.
And I appreciate all of that. I thought actually that the Bridges folks were supposed to be looking at, I can't remember what they call it, but sort of criminality or sort of issues. Yes, I didn't know that word, criminogenic. So I thought that was part of their charge. So maybe for the next meeting, we can make sure we have the duties of the Bridges folks. I'm trying to frantically look it up here, but that was my understanding.
What other questions do you have for me?
I just had one kind of follow-up comment to what we were just talking about there, and it seems like, the propensity for recidivism or recidivist behavior or violence may be a barrier to effective community-based restoration services, and so that's the reason why I was bringing it up. There's obviously a public safety component, but it seems like that's the low-hanging fruit to determine between inpatient and outpatient services.
Can I just add, this is Peggy Heil, that there are validated violence risk assessment tools that are available. I don't know if they work well with a restoration population, but.
Well, thank you all for your time. I really appreciate it. And please don't hesitate to reach out if you have any questions.
Lucy, you had your hand up. Do you still have a question?
I think we covered it. I was thinking that there were prior conversations that the evaluators could provide a clinical assessment of appropriateness in the community, but not a risk assessment to do that. But I think we've covered that. I do, from a practitioner's perspective, I feel like in interactions with the court and prosecutors and police that sometimes violence is overemphasized with the mentally ill population, that there's somehow a connection that's drawn there that I think part of our effort should be disconnecting that belief a little bit. So I think that's the public defender speaking in court to that issue. But again, risk assessments are available to Peggy's point.
I just want to point out that, I think if somebody's severely mentally ill, not engaged in treatment and is using substances, their propensity of violence is more than general population, that subset of people. The rest, I wouldn't say need to be stigmatized, but if you meet that triad, I would be concerned about those people.
So I want to thank everybody for this discussion, and thank you, Catherine, for the overview and presentation. This has been very rich Q&A, and appreciate everyone's comments and questions. Due to the nature of that presentation and the extensive Q&A, we're going to switch gears a little bit. Robert, anything that you want to say, or Allison, to kind of wrap up or conclude that discussion, and then we'll talk about homework assignment or next steps.
We'll come back to this topic. There is a place in the intercept model in the plan for us to flush this out even more. So we'll definitely come back to this topic because I do think it's critical to making sure that people are not more restricted than they need to be, and that we are using our hospital beds just for those that need hospital beds. So we will definitely revisit this. I think this is really helpful, hearing some of the different components of who's going to do what. So we'll have to sort of flush it out, put a sort of more visual component on the PowerPoint, so we could talk about, when we talk about community restorations, what falls where and where the opportunities are. I agree. I think this is all really helpful. We've been sort of working on this, but this is the one. It's new, so there's opportunity to sort of. So there's opportunity to sort of enhance this, and it is new, and it is a new program, and we should be thinking about the entire system. So we'll come back to this in a section, the intercept model. It falls nicely in one of the categories. We'll flush it out. I'll take the questions we had today
get some more detail. And then when we do that, I will also, if this group decides that the safety net, the state safety net needs to be a key part of this, then I'll bring that to the safety net subcommittee as well to talk about what this group has decided upon. We're gonna, before I get to Allison, we're gonna switch up the agenda a little bit because there's not gonna be time to get in small group discussion. So I'll let Allison make some comments, and then I want to come back to the questions that you have in front of you. For those on the phone, they have they do. Okay, so we'll go over this real quick and discuss in more detail in our next meeting.
The only thing that generated all this discussion, but that's, you know, sort of the hopeful view of how it's going to work. And obviously we've seen that the numbers are not going the right way yet. So, you know, I've written down 5 major issues that this group came up with, and I do think we have the work in front of us. I just don't want us to be fooled into thinking, oh, it's already figured out, because although there is sort of a plan in place to figure out how to fix it.
I completely agree. The resource question is a key question. What the Catherine group was originally charged with, and what the program needs to morph into are 2 different things. So as we move forward, it's going to be critical. And answering some of the questions that we've heard from all different perspectives is going to be critical in creating a program that people will use. I don't want to create a program that people are not going to use. So I think that'd be great. So we'll get real quick. We'll go. I want to go over these questions real quick, and then we'll open it for public comment. Oh, go for it.
If you unmute yourself and talk loudly.
Raina, we can't hear you. If you could be sure that you are unmuted and talk as loudly as you can into your speaker.
Was there a question? I couldn't hear the last person.
Raina, if you had a question or a comment from Zoom, we would love to hear from you.
Not at this time.
Okay, thank you. So there are 2 questions that we were going to do in small group. I'm going to be like my elementary teacher and give homework. And then what we'll do in our next meeting is to get in small groups, and then we'll have a time at the end of the next meeting to get back together in a large group and discuss sort of where we're going, because I think these questions are pretty important, particularly the second one, but both of them. Question 1 is hearing a little bit more today about community restoration and getting a better sense. We'll have time to talk about inpatient services, and we'll go through each section of each part of the process. But what is the function of this subcommittee? And you should have a handout in your packet that you got on the table this morning, and those online have been shared through Zoom. Is it just to improve the competency process to get someone well enough to stand trial, or is there more of a role to help improve access to mental health services resources in Colorado? That is critical. We're sort of probably have to do both. Well, my opinion is both. I guess you can go home and decide what you think. It's a question to you. So what role do you see the subcommittee as far as charge? And then what are the priorities or the big issue areas the subcommittee should focus on? And I really want to hear from the entire group. And we will, for the most part, encourage people to participate in the next meeting and talk about what they want us to focus on, because I want your time here to be meaningful. I want your contribution and what we're doing here to be meaningful to you. I know you're giving up a big chunk of your time. And I think it's important, and for it to be meaningful, I want to make sure we're addressing the topics and the areas that you all want to see addressed. So if you could just ponder those questions, think about them, and then we'll jump right into them to the next meeting. Great. And then any questions on the 2 questions for homework assignment? Feel free to take this home, write it up, bring it back next time. If you think of something and you're like, oh yeah, I don't want to forget about that. Great. And then I'm going to turn it back over to Emma.
Now we'd like to welcome any public comments. I will run the mic to you, so just raise your hand. And do we have any public comments from Zoom? You can either send through chat or unmute yourself now and speak loudly. And if you're on the phone, it's *6. So then we just wanted to quickly review the meeting schedule. So we worked to secure standing meetings moving forward. For the month of August, we'll be a little bit off schedule. So our next meeting will be Monday, August 12th, 9:30 to 11:30 a.m., the same time as what we met today. We're working to secure a location. And then Thursday, August 29th, please hold 11 a.m. to 2 p.m., where we have an opportunity for a presentation from the special masters. And Robert and Allison, would you like to share a little overview of that opportunity?
Yeah, real quick. Since our next meeting's pretty far out, you have lots of time to ponder the homework assignment. But feel free to email the Farley Center or Summer if you come up with ideas and you don't want to wait to the next meeting, you want to share it with them so they could put it together. So feel free to email those folks. Also, connect with them if you want to participate more in this group or you want to look differently. I know I'm pretty vocal, pretty opinionated, and I have no problem speaking up, but we all have different styles. So if you feel like you're not being heard or there's a format that would work better for you, I want to make sure that we are open to mixing it up, the meeting, so that it's, well, not the same people, me particularly, talking all the time. So feel free to reach out to them and they will manage that process as well. Allison said she's good.
So the Arizona Supreme Court, the conference chief justice sorry about that. Oh, good. Anyway, let me start over. The Arizona Supreme Court is hosting a training on the sequential intercept model, which is the thing that's kind of behind you. And so I know that people here have different levels of understanding and expertise, but it's a free 2-day training. They're doing 2 the first week of August, Monday and Tuesday, and another one on Thursday and Friday in Flagstaff. And if anyone wants information about attending, I can provide details. As I said, it's a free training, and my sense is it'll be a really good primer as to how it is, how it works, what it is, and then how to be able to implement it in Colorado.
All right, unless there's anything else, I think we'll call that a wrap. Thank you.